For this lecture, we'll begin looking at deep vein thrombosis. This is a continuation of our peripheral venous disorder lecture. Unfortunately, DVTs can be asymptomatic. Oftentimes, we'll just have general malaise in that lower extremity. It may not be until it either manifests as a PE and we become short of breath or have changes in LOC that we actually go to the hospital. If we are fortunate enough to catch it either at home or just because we came in for some other reason, what you would generally see is severe calf or groin pain. Again, because it can be asymptomatic, you don't have to have pain, but if you do, that pain is probably going to be associated with just that compartment syndrome type of process that's happening with the edema going on. You can have just generalized cramping in the affected leg, usually in the calf. You'll have warmth, edema, induration, hardness over the blood vessel that is currently affected. And then we'll have changes in the circumference of the calf or thigh because of the localized edema. From a prophylactic perspective, we're still going to do our patient teaching. We're going to encourage this client to rest, right? If you've been diagnosed with a DVT, I don't want you up and ambulating because now you're going to make that turn into a PE or a stroke or an MI to wherever that clot is dislodged from to where it goes to. You can still do elevation of the unaffected extremity above the level of the heart because we know it's still a venous disorder. But be careful. We don't want to use any knee gatch types of putting the pillow underneath the knee directly. You want to make sure that it's at the ankles because obviously this client is already experiencing some of the signs and symptoms of a DVT. This client here in the picture, it's on the left leg, but now we're going to be promoting the development of a DVT on the other side. So be careful with that. And again, with venous disorders, it's above the level of the heart. Arterial is below the level of the heart. Teach your clients not to massage the affected limb. Teach yourself and your techs and whoever else is there. We don't massage the affected extremity. That's going to dislodge that clot. So generally what we see is from a patient teaching perspective is when you have irritation in your lower extremity, when it's cramping, one of the first kind of things we go down and do is we rub that area. So we've got to make sure that we're following through with that client to make sure that we're not causing a PE. They can continue to wear SCDs or compression stockings on the unaffected side. Just don't put those compression stockings where the DVT is. Few diagnostic tests we have available to us. The venous duplex ultrasonography is probably going to be the big one that we send them down for. It's going to give us blood flow in real time, hopefully allow us to visualize the blood clot through the blood vessel. At the bedside, we can use Dopplers because you can still have a change in the pulses because of those compartment syndrome type of symptoms. And that's going to help me as the nurse to make sure that they're still perfusing. If we are having issues and we still can't figure out whether or not it's a DVT, they can go down for a venogram, which is just like an arteriogram, except it's obviously in the venous system. But remember, that's still going to include the use of a contrast material to help us visualize blood flow. Or they may get an MRI. Again, I don't see too many MRIs being used in the healthcare setting, but it is an option. Couple of medications, either prophylactically or acutely, that we can give. Prophylactic unfractionated heparin is going to be the subcutaneous heparin. We're going to give that. Make sure you're rotating your sites. Make sure you're that 1 inch away from the umbilicus, wherever. And make sure you're still monitoring their laboratory values. If it's a continuous infusion of heparin, we're going to have to be drawing a lot of labs, unfortunately. Generally speaking, it's going to be about every 6 hours until our PTT becomes therapeutic. And we'll look at a heparin nomogram later on. I would say the continuous infusion of unfractionated heparin is probably the most common one for a known DVT, but sometimes, depending on the size, we can still continue to use enoxaparin, that low molecular weight heparin. It's just really down to physician preference. For unfractionated heparin, that's going to be a continuous infusion. You want to make sure you're not mixing it with a lot of stuff, probably its own dedicated line. You're going to continue to monitor that APTT. You want it to be in that therapeutic range. We've looked at the normal kind of 20 to 30 number is where you and I should sit. So if it's 1.5 to 2.5, we know that that therapeutic number should be around 60 to 80. Anything greater than 90 is going to probably require immediate intervention, but that just means we're probably going to hold the heparin for an hour and then restart it at a lower dose based upon what their last PTT was. Still going to look at platelet counts. We're still going to make sure that we have access to protamine sulfate. And then we're still going to do our patient teaching about bleeding precautions and make sure that they recognize signs and symptoms of feeling different, adverse purplish discoloration, that purpura. But that's not a big one for us. But if they have an active bleed, if it's coming out of their orifices, then that's more noticeable to me as the nurse. Obviously, if they have changes in LOC or chest pain or something like that, that's a big issue for me as well. Enoxaparin, the big piece for that from a nursing perspective is make sure that you're keeping that air bubble in. That's supposed to be in there. It comes up in a pre-filled syringe. It's going to be based upon the client's weight. We're going to explain the purpose of it. We can send them home with enoxaparin, BID, twice a day, but that's typically not done because of compliance issues. But we're still, if we would do that, we would still instruct them about monitoring signs and symptoms of bleeding, and again, using those safety precautions. The electric razor instead of a bladed razor, the soft bristle toothbrush, avoiding IM injections. If you hit your toes, make sure you're inspecting your feet. Warfarin, if given, will probably be given or started at least at the same time that the heparin or the continuous heparin is going, because it does take longer for heparin to take effect. Here we see it's 3 to 4 days before they become therapeutic. We say PT, INR, but mostly we go off the INR, so I'm not overly concerned that you recognize what a PT is. A normal therapeutic would be about 10. But it's the INR in warfarin that I am concerned with, and I just remember 1, and that the desired therapeutic level is going to be 2 to 3 seconds because it's 2 to 3 times 1. And obviously, if they become greater than that, or if they're less than that, we have to do either increase the dose or withhold the dose. A lot of that is going to be weight-based in the healthcare setting. And if we're discharged on it, we got to do our patient teaching about making sure that they're coming in and having their laboratory values drawn. We're still going to do all that same patient teaching for bleeding. In the healthcare setting, we're going to ensure that we have vitamin K. And then we're going to do some patient teaching about green leafy vegetables. We still see that question out there in your practice exams. Making sure that they understand, I'm not going to tell you to not eat green leafy vegetables. We're going to say use it in moderation, making sure that you're monitoring for all of those signs and symptoms. And then if you do feel that you're having an adverse effect because you're eating too much green leafy vegetables, you're going to have some lab work done, or they're probably going to increase your dose to compensate for that. And we do see that warfarin can be used for any number of reasons here. It's being used prophylactically to prevent all of these disease processes. If I have a DVT and it's an acute situation, I can prepare them to be sent down if they're actively producing clots. If they have something like DIC, disseminated intravascular coagulation, where they're producing a lot of clots. We can go down for a filter trap. Now, filter traps have been in the news fairly, well, nursing-wise, fairly recently. recently because of some adverse outcomes. But basically, it's a big net that's put in your venous system to catch clots, and hopefully that your body will dissolve the clot over time. If the client is more acute, we can go and send them down to the cath lab, and we can do an embolectomy or a thrombolectomy, whatever it may be. And again, those signs and symptoms, those nursing considerations are going to be the same. You're still going to assess for bleeding. You're still going to observe the insertion site of whatever catheter we use. You're still going to assess distal pulses. So none of that really changes for us. So we know then that DVTs, if untreated or undiagnosed, can develop into a pulmonary embolism. So we talk more about PEs because that's the most common one, but remember, it's still wherever that clot travels to is where we're going to have an issue. So if the clot travels to the lungs, obviously it's a PE. If it travels to the coronary arteries, it's an MI. If it travels to the brain, it's a stroke. So be thinking about those as long-term outcomes for DVTs. Probably the priority intervention for pulmonary embolism is going to be the administration of supplemental oxygen. I've always make your decisions based upon the client's signs and symptoms, what you see objectively. In the past, I've experienced getting a report from a previous nurse. They said, they're agitated, they're anxious, that's just their baseline. So obviously, at the time I was an LPN, didn't know a whole lot. The answer to that would have been Xanax or Ativan. And then later on, when we obtained a full set of vital signs, you notice now they're desatting. So anytime you have changes in acute changes in LOC, make sure you're getting an SpO2. Client should have been on continuous SpO2 anyway, especially if you suspect that they are having issues with DVTs or PEs. And then, of course, we're going to start this client supplemental oxygen, maybe something for anxiety, because lack of oxygen will make you anxious, such as morphine, the other medications, the alprazolam that we talked about. And then, of course, that anticoagulation therapy. If they presented with a DVT and now we suspect it's a PE, what you're probably going to see is a sudden onset of dyspnea, tachypnea, pleuritic chest pain. Again, we keep seeing this chest pain issue over and over. Apprehension, cough, and hemoptysis. So we now have this cough where we're seeing it red tinged. So it's going to be productive. If left untreated, they can develop crackles, a pleural friction rub, tachycardia, new heart sounds in S3 and S4. They're going to become diaphoretic. They can have fevers. They can have petechiae. Petechiae is never good. It's your microvasculature is basically bursting. And of course, the big one is probably going to be this decreased oxygen saturation. You want to raise the head of the bed, give supplemental oxygen, and prepare to administer anticoagulation therapy. We can do a D-dimer. It's still out there on some of those practice questions that we see for a PE. It's a coagulation study. So we're going to look at a positive D-dimer. And of course, we're still going to expect that they're going to go down for that duplex Doppler ultrasonography or that venogram to make sure that it's actually a PE that they're having. Starting on them on continuous heparin, you want to make sure that you're going to monitor the 4 Ps. That's the pulses, your PTT, their pain, and their platelets. And that will help you to determine what are your priorities. Obviously, if it developed from a DVT, and I had a DVT once, I can develop another DVT. Or it could have been multiple clots that you had in your peripheral, and then one of those clots broke off, and now that's the PE, but we still have the problem of still having another DVT in our legs. So here is a typical heparin nomogram, and this is what you are going to base your decisions on. So it's important that we understand what a normal is. So we looked over here, it's that 25, 35 seconds. This book says 46 to 70. This is from your Lewis book. But you can see over here, this is SSM's policy, or it was at one time. It's a little bit different, and that's okay. We're going to have different numbers depending on which institution you work at. But we know, again, if I'm seeing numbers greater than that 90, and I use 90 just because that's easy to remember because it's the same one I would look at for my systolic blood pressure, that you're going to have to do certain things. So what we're going to have to do is I'm going to evaluate my PTT every 6 hours, and I'm going to make adjustments to my rate. So if my initial PTT comes back after 6 hours, they've been diagnosed with the PTT, and I see that their PTT is 45. So that would fall under here, right? I'm going to bolus them, right? And then I'm going to increase their rate by 150 units per hour. Heparin's pretty good because it's usually 25,000 units in a bag, so it's not a whole lot of math that we have to do. It's pretty much a one-for-one kind of situation. You do have to make sure you're looking at whatever bolus dose that the healthcare provider wants started. And usually they're going to base that upon the client's weight. So then in 12 hours, I come back and I see now that their PTT is 80, which is here. Now I'm going to have to decrease that rate by 50 units per hour. So we're going to keep doing this every 6 hours, basically until I get about 3 of these that are therapeutic in a row, and then you can switch over to every 24 hours. If you come back with these really absurd high PTTs, again, you're probably going to hold the heparin and then reduce the rate by a greater amount. And here it talks about the time frames for your PTT and then notifying the healthcare provider. Again, this is going to be different. I would expect now with the next generation questions that NCLEX would give you this information so that you can make your assessment based upon known information in your MAR. But you will have to, for the test, know what is normal and what is therapeutic, right? If we consider that this is really acute and the heparin's not working, or we just need to do something immediately, we can use thrombolytic therapy. We've discussed thrombolytic therapy in the past. Most common is going to be TPA, the tissue plasmin activator, and that's going to go in and that will actually dissolve the clot. Unfortunately, that also increases greatly your risks of bleeding. So the probably quickest indicator of some sort of internal bleeding is going to be changes in LOC. I'm going to evaluate the effectiveness of that TPA by the client being able to breathe normally, that they have clear lung sounds, that they don't have changes in LOC. All right? And we're still going to do a lot of patient teaching over bleeding precautions. So those are the basics of PAD, PVD. So now let's just kind of generally review what we've looked at so far. So this is a breakdown of PVD versus PAD. Here we see those acronyms to help us remember for our signs and symptoms. So on the left hand here we see the pedal. It's a pedal pulse, right? And on the right hand side, theirs is I cried in pain. Don't care how you remember it. This is a nice little breakdown of what you need to be thinking about. So because of VCAU's triad, right, we want to restore blood flow. We want to keep them hydrated. We want to make sure that they are early ambulating. and we want to make sure that we're elevating the extremities, and we're going to use SCDs, and then the big NCLEX ones are don't cross your legs, and then don't dangle your legs. On PAD, we've talked about it's the eye cried pain, basically things you're looking at. Keep them warm, right? Make sure that they're exercising, that we can use our vasodilators and our antiplatelet medications, and then making sure that when you are answering questions about PVD versus PAD, you're looking specifically at what the question is asking you. And I like the middle section here, right? Because it talks about, is this true or is this false? And we know that. So with PVD versus PAD, do you expect pain? Well, we said no, but you could have some cramping over here. And PAD, yes, we do expect pain. PVD, I would expect a pulse. Over here, I would expect diminished pulses, weak pulses. Color changes. Paresthesia. I do expect paresthesia with PAD. I do expect pain with PAD. Do we want to use compressions with PAD? No. Do we want to use it with PVD? Absolutely. So it's just a nice way to break down and disseminate which information is important to which. Again, answer what the question is asking you. PAD, PVD are some of the most often missed questions because students get so enamored by those answers that look really good that they forget that the question is asking you about PVD. So would I expect, let's say, diminished pulses with PVD? So no. Which assessment would the nurse expect? Well, I would expect that their pulses would be okay unless, of course, we had that DVT. And then we have another issue. But the questions will or should be giving you specific information to allow you to make the correct choice for your care. So this wraps up our lecture for PAD and PVD. Again, make sure if you have questions or you need clarification, you're coming and asking me.